Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
Just launched by an East Bay fertility doctor.
Hi, everyone. Welcome to another episode of the Egg Whisperer Show. I'm Dr. Amy, your host, and I'm so excited to have Dr. Mann on today's show. Hi, Dr. Mann.
Hi, Dr. Amy. Good to meet you. Good to see you.
Nice to see you.
Thank you so much for having me.
I am so honored to have you on today's show. And the topic is everything you need to know about Asherman syndrome from an expert. And you are definitely our expert. So before we start asking you all sorts of questions, I want to start off by reading your very impressive bio. So you graduated with a BS in Biology and Chemistry from Florida International University in Miami, Florida, receiving your medical degree from University of Florida School of Medicine. You also did an internship at MD Anderson Cancer Center where you researched chemotherapy as treatment for early stage breast cancer. And then you went to residency in OBGYN at NYU Langone Medical Center, where you were part of a Latina Share series to educate the community about GYN cancers. And then you did a fellowship at University of Connecticut in 2010. You're board certified in both reproductive endocrinology and infertility and obstetrics and gynecology. And that's why you are our expert today. So thank you again for joining us. So what I want to hear, first of all, is tell us about your practice. Where do you practice fertility medicine?
Hi. Well, again, thank you so much for having me today here. It's my pleasure to be part of this series. I am in New Jersey, in a town called Old Bridge. So it's like central Jersey. I've been here for almost 10 years now.
Wow, that's awesome. And then what made you become a doctor?
Well, it's basically, I think over the time that I had in college, I really wasn't sure of my path, but I, was involved with various clubs and organizations, and my desire to always help and give back, in addition to the amount of science that part of the curriculum in medicine is what made me, pursue the path of medicine. In addition, my stepfather is a physician, and so I think part of that was an inspiration from him, knowing how much work he put into what he did and how passionate he was about his patients. I had to figure it out on my own to some extent. My family was very supportive, but that's what made me, pursue a career in medicine.
And you told me a little story about when you were 10 years old. Can you share that with our audience too?
Yes, I still, it's interesting. I think you remember certain things and little things sometimes stick with you. So when I was thinking maybe like 8 or 10, I remember my stepfather was in medical school, and he would bring, home arteries and formaldehyde, and he would practice like sutures. So yeah. He would have me help out. And so yeah. I did that, and I saw him tying knots, all over the house, as you probably have done. So, right. Remember doing that. Yeah. And I just thought this is pretty cool, Yeah. So, that's, I think, part of what sparked my interest.
And what led you to become a fertility doctor more specifically?
Well, I think it started in Florida. When I did my clinical rotations at the time at the University of Florida, I had done, volunteering at the Children's Hospital, Miami Children's Hospital, and I was convinced I was going to be a pediatrician, pediatric oncologist maybe, because I really was interested in science and research. But then I just really fell in love with women's health and taking care of women and being an advocate for women. I just thought that was really where I found my voice. So that's what made me become an OBGYN. And then during my rotations, I also was marveled at the science behind the world of REI. At the time, I remember that the pre-implantation genetic testing, as we know it now, was called like PGD only. And we were testing for only 5 genes, so it was quite amazing. So one of my mentors there, Dr. Stan Williams, actually said to me, well, if you want to become an REI, you probably want to head to NYU. And so that's where I went.
Nice, nice. So I don't know if you get this as a woman. I have people asking me all the time if I needed help getting pregnant. Do you get that question a lot?
Yes, I think that most of the time when women find out that, this is what you do, I think they share a lot of things, whether it is a concern about their specific story, which I'm more than happy to help, or they also share with me, what I found, Dr. Amy, is that they tell me their stories of what has happened to them. They tell me that, they are very appreciative. They thank me for what I do, even though I wasn't the one helping them, but they tell me their stories.
Yeah.
And I find that, I am very privileged to share that and to be somewhat of a person that they confide in,
Right.
It's nice to talk about those things and to realize that it is more common than we think.
Right.
There are so many women struggling with infertility, men, and that's the other part that, we won't talk about this in this particular show, but it's everywhere. Men, I'm sure, suffer as well. You know what I mean?
And so what do you share with women when they ask you if you had a struggle in your journey?
Yeah, so I actually tell them a few of the patients and the people that I know. I mean, there are a couple of things, but I did have a situation with a condition called Asherman syndrome, which is going to be the topic of our talk today. So we'll discuss that more, but I did tell them it's not easy. We've all been faced with miscarriages. We've unfortunately, that was also part of what led me to develop Asherman syndrome. And this is a condition that I think sometimes goes unrecognized. And it's thought to be very rare. And I believe it is. But if it does become, if it's something that we can identify early on, then it can be treated.
Mm-hmm, mm-hmm. And what is it? Can you define it for our audience members?
Yes, so Asherman syndrome is what's considered like an acquired condition, meaning it's something that people are not usually born with, but it's usually causes scar tissue of the uterus. And essentially this happens most of the time as a result of a surgery, or a miscarriage. Sometimes patients don't end up passing all the tissue, and you have retained tissue. And the retained tissue, whether it can become mildly infected or like what we call subclinically infected, can cause scarring. Mm-hmm. And that can lead to subsequent miscarriages or the inability to conceive, depending on the degree of the scarring.
And you kind of already mentioned, what other names for it? Because sometimes you and I see patients and they don't know the actual word Asherman syndrome, but it's been described in their medical records and they didn't put the two together. So what other names are there for Asherman syndrome?
So there are other names, uterine synechia, and we see that a lot. Intrauterine synechia is a description and just means that scarring inside the uterus. That's what intrauterine synechia means. Mm-hmm. And essentially just scarring of your uterus. So people sometimes describe it as, but the other name or more formal is the Asherman syndrome.
Mm-hmm. And you mentioned risk factors. So the risk factors are generally a prior surgery?
Correct. A prior surgery, say that somebody has had a difficult delivery and sometimes they have, they need an extraction of the placenta. There's a manual extraction, and sometimes tissue stays in the uterus, and that can cause scarring as it then can heal, but it becomes calcified and it causes significant issues in the uterus. So previous instrumentation or delivery.
Got it. And then how is it diagnosed?
Well, there are two ways to diagnose more definitively. Like there's the non-invasive way, which is, like an HSG, a hysterosalpingogram. That's what that means. And this is a test that is done as an outpatient procedure where a patient will go into a radiologic facility and, we'll put a little catheter through the cervix, goes into the uterus, we fill it up with the dye, and then we'll take an x-ray. And so it's an x-ray picture of the silhouette of the uterus. And so that's how we can see the scarring. The gold standard for diagnosis is a surgery called the hysteroscopy, and in that way you can see it and you can actually treat it.
Mm-hmm. And then if someone hasn't had a diagnostic test like that, what kind of symptoms should they look out for that might be a sign that they could have it?
Well, one of the symptoms may be that they don't get periods. So, somebody had their baby or somebody had a DNC and they don't get periods. And yet they may still feel like what we call like cyclical pain, meaning like once a month I feel this pain, like I feel like I'm going to get my period, I feel bloated, but then it never comes. And that can be devastating. I can tell you that. We'll go more into that, but really it can be very painful because instead of you have your lining that builds up, and instead of coming out through the outflow tract, like through the cervix and the vagina, it goes and backs up and it goes into the tubes. And so it can be quite painful.
So, well, let's talk about that a little bit. So let's say that does happen. What kind of procedure would you need, and how emergent of an issue is that, or how urgent of a situation is that for somebody?
Well, it really depends. And I would say that it is quite urgent because it can cause significant pain. And, when we talk about Asherman's, we talked about the one presentation where you have what's called no period or amenorrhea. But there are other presentations where, you may have noticed that your period is not as heavy as it used to be, right? So now it's a little lighter. I just have some spotting, and, you could get pregnant, but then miscarry again because there's scar in the uterus. So that's another presentation. And, anybody, like that has had that history of either like a DNC or has had any concern that something is changing, it's not a bad idea to discuss this with your doctor, because there are different parts within the uterus or down, to the lower uterine segment, and that can be scarred and essentially closed.
I get a ton of questions, and I'm sure you do too, especially right now with the pandemic. Everyone's really focused on trying naturally. And I get a lot of questions about cervical mucus. Are there changes in your cervical mucus that you would notice if you had Asherman syndrome?
Well, in general, like the cervical mucus can actually is usually thinner, like at the time of the cycle, right? Middle of the cycle. But that might be not fully produced. And so it may not be the same. So you don't have the thinning, nice, like white, clear egg white, like people call during the time of the, like you usually would have it before.
And do you have any suggestions for people who have, aside from treating the Asherman syndrome, is there anything that you suggest to help with egg white cervical mucus and increasing it?
I think that the cervical mucus is more like a sign of an issue. Is it like, the question is like, is it that you can improve it and thereby fix the issue, as opposed to, are you treating the problem? Like your mucus can improve, like certain things, like you've heard probably people use, guafenicin and things like that to make it better. So, but whether that substantially improves the problem, it's kind of like, I'm not so sure, you know what I mean?
Right.
Because
Right.
if somebody has true Asherman syndrome, that probably won't be the solution,
Right. So it sounds like the solution should be the treatment of the Asherman syndrome. So what kind of surgical techniques do you perform for your patients with this?
Typically, I do a hysteroscopy, and I would do a resection of the scarring with usually scissors. It depends on how much scarring is there, right? So like scissors are good for like whenever you have a scarring and you can actually cut them. So you use the scissors. I've also used another device called the MyoSure when we have scarring that is sort of more like a retained piece of tissue that you see there. It's a great instrument to remove some of those scars. So scissors, or, the MyoSure device. I've also used in the past a resectoscope, and I think it really depends on the degree of Asherman's that someone has. Now, with the resectoscope, so this is an instrument that causes cautery. So that is actually, you have to be careful, because sometimes you can cut too much and cause more damage into the endometrium, and we don't want that. We want to typically, that's, like I said, that I use it very, very rarely, maybe to just help me get there. But typically, scissors are best. in my experience. And then, like I said, the MyoSure, because these do not use any cautery. The concern, like I said, with cautery is that you can cause damage to those basal layers, the basal like cells that are going to regenerate. So you want to just cause enough so that you can create an area where the cells are going to regenerate and take the scar out from the top.
Right. And once you've removed the scar, do you place an intrauterine balloon catheter or anything like that, or put patients on hormones?
Yes. So the decision to place an intrauterine stent or balloon in the uterus is usually something that I will make at the time of the surgery, because I think that sometimes I'm not the type of doctor that goes and treats everything by an algorithm, which is why I loved looking at your bio, Dr. Amy. I have to say, you're great. I just so believe in that. There are many things that we have to, first of all, listen to our patient, and we have to do a diagnostic test before we can tell someone what to do, So yes, I think depends on the amount of scar that I see. So if there is a lot of scar and somebody has had a history, like I have patients that come, like I've had 2 surgeries with another doctor, I'll leave a balloon there. Depending on, their history. And so if there's a lot, yes, I will put a balloon. I always, whenever I have Asherman syndrome, I will have them take some estrogen supplementation afterwards. It depends on the patient too. Some patients that don't ovulate on a regular basis, and some patients who are a little bit heavier will make their own as they make higher estrogen levels. So the dosage also varies a little bit. Their BMI will vary in terms of some patients may get sick with too much estrogen. So right. That's how I take care of it.
Perfect. And the purpose of the balloon is to prevent reformation of scar tissue, and the same thing for the estrogen. Right?
Correct. So the estrogen hopefully is to prevent that the scars will recur. And the balloon, I usually leave it for 3 to 5 days. Mm-hmm. I give it to them with antibiotics, and I tell them that it can be a bit uncomfortable. I've never had to take out a balloon, other than there was only one patient in my whole was 20 years of doing this that I think she was very uncomfortable at the time, and it was right after we did the surgery. I had to just take it out. She couldn't handle it, but for the most part, it's tolerable.
Good. And aside from the procedures you just described, there are some other newer therapies that people are talking about. So, for example, Neupogen infusion in the uterus. What do you think about that as a therapy for Asherman syndrome?
I have to tell you that I have seen reports of that. I think if you are probably, we failed all the other therapies and this is the only thing you might try, I would say, go to a center that has a lot of experience using Neupogen, just like anything, Fortunately, I've been able to help all the patients, that I've had with Asherman syndrome, fortunately, like I said, and I haven't had to resort to the use of Neupogen. I think it makes sense that it could be useful, but it hasn't been my experience to use.
And then what about fresh amnion graft, Viagra, aspirin? What do you think about those types of options?
So again, and the thing with, Neupogen versus the other things that we're talking about, or any other of grafts and stuff, that you always have to weigh the risks and benefits, right? Experience as to what you're going to do, and then what are the risks for the patients and what is the benefit. So with that, I have used Viagra. It's not one of the first things that I use. So usually what I use in the immediate after somebody has surgery to remove the Ashermans, we do the estrates. And then if they are going to go through a cycle, let's say I want to do a mock cycle now to just check how they develop their uterus. So I always like to see, okay, how are we doing now? Let's measure your lining. Let's see how it looks. So then I can add vitamin E. So that can help also improve uterine flow. Usually we do 400 IUs twice a day. And Viagra can help also, but again, it's one of those things that I will do later, minimal risks with vitamin E. So side effects of Viagra, it's usually used vaginally. So the side effects are also minimal as well. But it's, again, the same thing, that it increases the amount of intrauterine flow immediate. So that will help with, the healing and the improvement of estrogen. And that is how I use, but I don't use it as a first line.
Mm-hmm, mm-hmm. And then what about acupuncture? Do you think acupuncture helps your patients with Asherman's?
Well, so in general, I think with patients that have thin endometrial linings, and again, it's all like, you're going to find a paper that supports the use, and you'll find another paper that says it probably is not beneficial, right? So, but I always say to patients, if you're not bothered by an injection and a needle, then I think it's worth a try. I have seen some studies that suggest a trend to improve the lining of the uterus. So, I mean, I think, again, going back to what is the risk, if it's expensive for you and you're more worried about, and it's causing more stress for you to be having to pay for this, session, then maybe it's not worth it. But if it's something that you can handle and you would like to try it, I mean, a lot of things in terms of acupuncture and stress reduction, it can also be helpful. But I have seen some studies about improvement of uterine flow.
Good. So what kind of things should a woman who has Asherman syndrome think or be counseled about related to pregnancy? Are there any particular pregnancy complications that could come about from having it?
Yes. So, I mean, we know that there is, because you have Asherman syndrome, if we've had any issues with that you can get it again, right? After the delivery, there'll be a difficult time trying to detach the placenta. During the pregnancy, if the placenta invades more, there's a risk of a condition called accreta, right? So you have to be on the lookout, and hopefully that you don't develop a placenta accreta, which means, like I said, the placenta sits on top of the superficial layer of the uterus, is called the endometrium, and then it goes into the myometrium, right? So you can have like accreta, percreta, and so that it can invade through the whole uterus. And so different issues and problems with placentation are the things that you can encounter with patients who've had a history of Asherman syndrome and repair.
So potentially a woman who has had this would then notify her OBGYN that she's now pregnant, if the OB didn't know already, and then make sure that her pregnancy is managed as if it's a high-risk pregnancy.
Correct. I mean, and depends on, on what it has to be specific, because,
Right.
I wouldn't say that they need to be consider, like the term with high risk, some people don't understand really what that means, but certainly that we need to be paying attention to this placenta and treat it as someone that has a higher risk of potentially an abnormal placentation. Correct.
Right. What was the hardest part about having Asherman syndrome for you as a patient? And then what can you share with our viewers?
Well, so, being a physician, and I first had retained tissue after I had my first baby and everything was okay, but then I got pregnant and had a miscarriage, and then after that miscarriage I had retained tissue. And that, again, like, if it wasn't that I know what I know, I would have been who knows what would have happened. But I was an REI fellow at the time, and I had my mentors take care of me, and they actually went with a hysteroscope and removed the tissue, and I was able to get pregnant right away after that with my second baby. When I had my second baby, the placenta did not come out right away, but it did. It was like 33 minutes. I love my OBGYN. She was very persistent, and she took it out. Actually, it came out fine. But then I was concerned. And one of those things is in the back of your mind, well, like, I have this, so what's going on with my uterus, right? Like, something isn't okay here. I ended up having, had an IUD. I had got pregnant with it came out. I had my third one. But after the third one, the placenta, like, I think not of it fully came out, so that's what happened. And then we found it a couple of months later. And at that point, I was like, something isn't okay. So we tried to remove it. And I went to another REI that at that time I was like in New Jersey, and it was pretty bad, came out. So there was like some time between the time, like, it's difficult because, I was nursing, I was a doctor, I had this third baby. I'm like, oh, this could be what's going on, but I don't want to be my own doctor. Like, we are always told, you don't want to be your own doctor. You want to take care of yourself and let the people that you trust take care of you. But it was difficult. I mean, I ended up having a lot of surgeries. I must have like 6 surgeries. Yes. So after that one, there were issues with that one, but we thought it was okay. And then when I stopped nursing and my periods came back, it was bad. I mean, I was like, something is going on and this is serious. So then I went and I was not getting period. I was getting the classic cyclical pain once a month. It was excruciating. I mean, I was like, doing something and bent over. It was just so bad. So yeah, I ended up going to Boston for 2 more surgeries, came back, and one of my co-workers, actually, my colleagues, helped me, and she took it out, and then I was fine.
Wow, good. Well, I'm glad you have relief from that pain. That sounds quite awful.
Yes.
Quite awful. So thank you for sharing all your insight and wisdom about Asherman syndrome. I think you have a unique perspective for sure because you experienced it yourself. So obviously you're not just an expert because of your training, but you're also an expert from the patient side as well. If you had a patient sitting in front of you right now, regardless of what she's going through, what would you say to them right now?
Well, I would say to them that, we, as a physician, I am with them. I'm their best advocate, and it's one of those things that we can never be too thorough. Let's just say that we can never be too thorough. Maybe I'm too thorough, but I'm sorry. When it comes to patient care, I think you really want to make sure you take a very good history from the patient. You listen to them, and listening to them will help you guide what's their best treatment. And I completely agree, with the philosophy. You have to find out a problem first before you treat something. So you need to make sure that you listen to the patient, and you can offer them the tests that are needed to guide their care and get them their best outcome.
Great. So can you just remind us again, where can patients find you?
Well, patients can Google me, Jessica Mann, and you can look for me there. It's pretty easy. ZocDoc has me there as well. My practice is called JSM Fertility. So I am on Facebook. I'm also on Instagram, JSM Fertility LLC. So please follow me. And if you have any questions, I'll be glad to help you. Again, as a physician, as a mom, as someone who struggled with my own issues, I think, I will do the best for my patients, and they will tell you that I do. So
we can definitely tell. Well, thank you, Dr. Mann, for being on today's show. It was so lovely getting to know you better, and thank you for being our expert in this series on Asherman syndrome today. Thank you so much.
Thank you, Dr. Amy. It was my pleasure. Thank you.
You're welcome. Have a great day, everybody. Thanks again.
You too.
Thanks.
Thank you. Bye.
Welcome to the Egg Whisperer Show, a program exclusively designed to promote reproductive health awareness and discuss fertility preservation options. Here is your host, the Harvard-educated fertility specialist, Dr. Amy.
She's known as the Egg Whisperer. Fertility expert Dr. Amy Abazadeh.
And you have yet another success story
just launched by an East Bay fertility doctor.